Okay, good afternoon, everybody. My name is Bill Becker from Tucson, Arizona. I want to first thank Sasha for the kind invitation to coming over to Los Angeles and sharing some ideas with you and some thoughts that we have related to implant placement. I hope you enjoy the presentation, and if you have any questions later on, you feel free to contact me. You'll see it's called Flapless Surgery for Implant Placement, and my name is there, Bill Becker, and my degrees are DDS, MSD, honorary doctorate from Sweden, and then the last one is EIEIO. I also sometimes been known as SOB, but I didn't put that down on this slide for today. Let's look at treatment plan 2. I think this is a 17 and a half or 18-year-old young lady. Her consultation with the orthodontist, growth and development has pretty much stabilized, and the patient came in with her mother. Now, let me tell you a little bit about this patient. You see, it's 19 years old female, congenitally missing tooth 7 and 10 are the right and left maxillary incisors. She's almost finished orthodontic treatment, and she has a domineering mother like you wouldn't believe. I mean, this woman smokes fire when she starts talking to you. She wants the best for her daughter. I've never had anybody come in and say, could you do the worst for my daughter? I mean, we all want the best for our children, but this one really wants super best. And to make things a little more complicated, she warns you that there's a divorce in the family, but her biologic father was a heart surgeon in Las Vegas, and her uncle's a dentist who will be checking my work all along the way. So, you know, you talk about the pucker factor. I mean, that will give you the pucker factor. But the girl, the daughter, is very nice, and if you can get around the mother, I think that, which we were able to do, we were anticipating doing treatment. We can see an anterior view. She's missing the lateral incisors, and we see 2 periapicals. The roots are appropriately spaced so that there is room for implant placement, and that's an important view. I'm sure everyone in the room knows you need to, after orthodontics, you need to have a periapical view. Sometimes the orthodontist put the tooth in the right position, but the root is angled in the wrong position, either closing or obliterating the space where we would have to ultimately place the implant. So we have to be careful. And then we take, as I said, 2-slice CT, so I can see that we have plenty of width and plenty of height. So that's really, it's always a concern, but it's not a concern in this patient. What's interesting is the teeth were congenitally missing, and usually we don't see that type and amount of bone volume for patients that are or were congenitally missing teeth. So here is a good example. I am trained and have been doing intravenous conscious sedation for, I don't know, close to 50 years. Again, we see the mark on the left panel, and we see the implant has been placed, and I'm using a plastic probe, not a metal probe, just to making sure that the head of the prosthetic table is appropriately placed beneath the mucosal margin, and then on the right side you see we're doing the same thing. Again, note almost no bleeding, a little bit of redness in the center panel, but very little to none on the right panel. Very easy to do. We did this with a surgical guide, but I don't think that I included the guide, and I apologize. But this was done with the guide, and if somebody has to see it, I'll give you my email address, and I'll be happy to send you the picture. So we see here, when she came close to finishing, I didn't like the gingival margins. They needed to be altered for an aesthetic reason. The teeth were starting to look like they'd be too short. So what we did is we did minor gingival plasty around the right lateral incisor and the distal facial of the right central incisor, just to make it a more harmonious and prettier look for this lovely patient. So there's the final photograph. There's the center view, and there's the left view. And you can see that it's using a very judicious diagnosis and treatment plan dependent procedure. Using this minimally invasive procedure, we were able to achieve, I think, a very aesthetic result, and By the way, the mother was happy and so was the daughter, but in this case we had to please the daughter before the mother. But I'm very happy in the final result of this patient. Let's look at another patient. Okay, patient number 3, 28-year-old female, excellent health, very good oral hygiene, missing the left lateral or tooth number 10 as a result of an accident. And she was wearing a flipper, and I don't know if anybody that really loves those flippers. I mean, patients hate them, as a matter of fact. She came in for a consultation and asked if she is a candidate for a dental implant. I apologize for the quality of the CT scan on the right-hand side, but I just wanted to demonstrate that we did take one. It's a lot better in manipulation, putting it into the slide. Something was lost. But if you look on the left panel, there's plenty of bone going from the crest all the way up to the floor of the nose. So that is not a problem. And the spacing between this central incisor and the canine is great for implant placement. So this is an ideal case when you finally come to the point that you feel you want to get into the aesthetic zone. This is a perfect situation to get involved with. So there's her flipper in place, and you'll see on the panel on the right, she's, again, IV sedation, but it doesn't have to be. You can do it very good local anesthesia, oral premedication, whichever works for you. But I'm using now the precision drill from Noble Bowel Care. I urge you all, if you're contemplating doing this procedure, to go over to the Noble Bowel Care booth and buy 4 or 5 of these, and you'll be smiling every day you use them. They're easy to use, they're very sharp. You use them 5 or 6 times and we just dispose of them and get another batch. But you can see that we have plenty of room. I mean, if, see, 7, maybe 7.5 millimeters. So all we want to do is make sure we get this implant in the appropriate place. Okay, and there I've finished the osteotomy. I'm using the guide pin. Now look at the left panel. Look at that. No bleeding. A little pink. No swelling. And it's really, really a minimized procedure. It takes a lot of time and planning, but I think the process is worth it. The guide pin has been placed. And there you can see it looks like a 13 or 15 millimeter Tyenite implant. By the way, I love Tyenite. I love these implants, and I think that the people that are running around saying that there's a problem with Tyenite surface, there's a problem with them, not the implant surface. My brother and I would not continue using these implants as long as we have if we saw the so-called problems that I really doubt occur to the degree that some of the supposedly self-appointed gurus claim there is. The implant, then, I got that off of my off the pedestal. The implant goes in very smoothly, and again, on the right panel, you can see that. Hopefully, you can see the prosthetic table is 3.5, sometimes 4 millimeters apical to the marginal tissues. And look at the final postoperative result. Go to a good dentist, a good restorative dentist who loves his job or her job, and most of the time you're going to get a fantastic result. This woman she's delighted. She almost dances up and down when she comes in the office for evaluation because the aesthetics are perfect, the phonetics are perfect, and a single implant really mimics as close as possible the adjacent central incisor. So it's a win-win-win for everybody using this type of approach. And so that we do see, that's a 3-year follow-up of the same patient. You can see things are staying very, very stable. Maybe a 0.5 millimeter loss of tissue on the left central incisor where the implant was. But I tell you, with her smile line, as you see in the right-hand panel, no one's going to ever see it except me. And there's the radiograph taken at 3 years. So we can see, initially we've seen several patients now, we can see in different parts of the mouth, areas of the mouth, this is an effective, aesthetic, and hopefully you'll feel predictable procedure. Thank each and every one of you for your kind attention. If you ask me what I like to do, I like to help a good friend round up his cattle, and once in a while we do a little shooting out in the desert. So thank you again, and I hope that you enjoy the presentation. If you have questions, there's my email address.
For more education programs, visit the gIDE Institute at www.guidedental.com.